Okay, welcome back, everyone. Dr. Sarah Dalziel is here today to speak to us about a recent conference that she attended. And so the floor is now yours, Sarah. Thank you for joining us here today.
Thanks, Fiona. So thanks for inviting me to speak to the AGM. I went to the conference in Australia run by Griffith University about a week ago, and the other New Zealanders there were who gave presentations to the conference were Ros Vallings and Professor Tate. So this is a really condensed version and summary of just some of the points in the conference. It's obviously impossible to cover all of it. And some of the slides of people's research is kind of tried to summarize several speakers. So I really apologize to researchers if I've haven't acknowledged you correctly, and also if some of it is oversimplified and not correct. I think it's correct, but hopefully it's not too oversimplified. Oops. Oh, hold on. I can't move. Oh, there we go. So there are several themes that came through in the conference, and certainly one of those was how challenging ME/CFS is to research. And Dr. Alain Moreau, who's from Montreal, likened ME/CFS as trying to solve the Rubik's Cube. You get one bit lined up and then everything else never quite matches. It's really difficult. And the reasons for this is because ME is such a heterogeneous illness. And what that means is that there's a really wide number of symptoms, and those symptoms are really different between individuals. So you can group people, there's lots of similarities, but there's also lots of differences. There's also, we don't know the cause. We don't know the pathomechanism of ME, and that's, I guess, what a lot of the research is focused on. But that includes looking at many, many different processes. So genetics, triggering factors, other things like metabolics, endocrine system, immune system. It's numerous things to look at to work out the pathomechanism. And for research into a diagnostic test or treatment, you kind of need to know what's behind it, what's causing it. There's also this huge overlap with other illnesses, and this came up quite a lot at the conference, that it makes it hard to define exactly who has ME. There's an overlap, obviously, with long COVID, fibromyalgia, Gulf War illness, and lots of functional illnesses, irritable bowel syndrome, and some functional neurological disorders. Also limited research because there's no animal model to study. The illness is too complex to replicate that in an animal. But there has been some attempts at this, and there was actually a good study of how they'd managed to get mice to develop post-exertional malaise. And so that's one symptom that they could potentially study with an animal by replicating post-exertional malaise. And time and again, the biggest challenge is also funding, to get enough funding to be able to put towards research. I've put the ME/CFS and long COVID slide up fairly early on because it was really another very noticeable trend at the conference that pretty much every speaker, every research paper now includes long COVID patients in their research. So they're often researching groups of ME patients, a group of long COVID patients, and healthy controls. So it kind of all goes hand in hand now. And that has some advantages in that there's quite a lot of funding overseas towards some long COVID research, and we hope that can sort of be channeled into studying ME patients as well. A bit of a difference, I'll come to that. So Beth Unger, who is from the States, very well renowned, pointed out that the experience that we have from ME really does help anticipate the care needed for patients with long COVID. And we can use some of what we know from research and clinical care to help long COVID patients. So it goes both ways. What a lot of the research studies are showing are that the longer you have long COVID for, it becomes increasingly similar to ME/CFS. So it probably becomes, you can diagnose people with long COVID and say, well, you fulfill the criteria for ME. So it's probably a phenotype, a type of ME. And certainly after 6 months and after a year, they're becoming very, very similar illnesses. However, in the early stages, so long COVID, we start to diagnose at the point of, being unwell with one symptom at 3 months. So a lot of those patients will actually have an alternative diagnosis that's made as a cause for their symptoms, or that their symptoms are actually due to some tissue damage from the initial infection, which explains what's going on. And I think it just brings to mind that we have to be careful that we're not missing alternative diagnoses. What seemed to come out from the majority of studies that was presented when they've studied these ME patients, long COVID patients, is that they're finding very similar findings between the two groups. So there was, I'll come to these TRPM3 studies, MRI changes, and some crossover with genetic findings. Warren Tate kind of likened long COVID to being sort of like the errant teenager, where some of the differences maybe just haven't yet been ironed out. They're not mature enough yet to, know exactly what's going on. So it's still early days for long COVID. And very briefly, this slide was just on long COVID. So a really good presenter and occupational health physician and public health specialist from Australia, Dr. Jerry Jurenko, who also worked in UAE during the height of the COVID-19 pandemic. And he put up a really nice slide to say, look how well people who had countries that had good infection control measures, high rates of vaccination before getting lots of infections did. So New Zealand, Australia, UAE all had really low death rates and probably have a much lower long COVID risk because of that. There was another poster presentation that sort of won the poster presentation prize for the conference, and that was a systematic review of they sort of did a meta-analysis of 12 studies that looked at who'd had COVID-19 vaccine and the risk of developing long COVID. And 10 out of 12 of those studies analysed showed that there was, if you'd been vaccinated, there was a significant decrease in getting long COVID. So nice to have that information. On to the complicated stuff of the studies. So the Griffith University, who runs the conference under the Professor Sonia Marshall-Gradiznik, presented a number of papers on their TRPM3 studies. And this is studying ion channels. And they collaborate with a professor in Japan as well, Professor Maraki. So what are ion channels? This is all quite complicated. So ion channels are on all cell membranes, and they allow ions, calcium, sodium, magnesium, all these ions to get in and out of cells. And different ion channels have different functions on cells. TRPM3 ion channels are calcium transfer channels, and they're found in high concentration on all sorts of cells throughout the body, but particularly in the nervous system and in the immune system. And they're triggered by sort of threats and on natural killer cells, and that increases cytokine response as one example of what they do. So the team at Griffith University have studied these TRPM3 ion channels, and what they've shown is that in people with ME and long COVID and Gulf War illnesses, so all kind of overlapping symptoms, that those ion channels don't work properly. They don't allow calcium into the cells, and so the calcium can't do, the cell can't do what it's supposed to do. And what this has led on to is actually trying to see, well, could there be a diagnostic test developed? And they have indeed done a test, got that here, of they've studied, sorry, I'll find it, they've studied 120 ME patients and 113 controls in the laboratory, and they've found that 86% of the time their test is accurate to say, yes, you do have ME CFS. That's really exciting, but there's a long way to go for that to actually be a diagnostic test for ME. One of the limitations is that this is a laboratory test. It takes 3 hours to do one test. It's very expensive, and so it needs to at least be able to do a high throughput test where you could send off a sample and it comes out the other end quite quickly. The other limitation, I guess, is that with 86% accuracy, what happens about the other 14% of people that don't come up positive? Do they then get put on the shelf to say, I'm sorry, you don't have ME? What do they do? How do we know? You know, there's quite a high number of people that it may not be useful for. The other work that they're doing at Griffith University is just looking at how low-dose naltrexone works. And so on these TRPM3 ion channels, there's a mu-opioid receptor that helps it to work better. Low-dose naltrexone binds to the mu-opioid receptor, and when it restores TRPM3 function. So with an ME patient. So just to clarify, in ME, they've shown that the TRPM3 ion channel is not working properly. You give people low-dose naltrexone and it restores that function. That is just in the lab again, and that has not been translated into any clinical trial for LDN and ME/CFS. And I think it does, it's probably not quite as simple as that, because we know that not all patients who use LDN actually feel better. I'm just backing up a few steps, that if we're talking about calcium moving in and out of cells, and just it's important to note that drinking chocolate milk's not going to restore that ion channel function. It's not about how much calcium you have in your bloodstream. It's about that actual ion channel function. There was then a whole lot of presentations on MRI studies and what's been found in ME. And what they've seen is that there's both structural changes and functional changes. So there's increased volume in some areas of the brain, the hippocampus, which just sits just above the brainstem, the pons and brainstem. So the brainstem area is our kind of regulatory functions. Is related to memory, concentration, sleep, fatigue, pain perception. They've also shown that there's some changes to myelinations in the sensory motor areas of the brain, and they propose that that's actually kind of a compensatory response to brainstem changes. So brainstem isn't perhaps working quite as well as it should, so there's this compensatory effect. Important to know that none of these changes are degenerative changes. They're not, hopefully not permanent, but they're not kind of an ongoing degenerative brain disease changes. They've got these new fancy pants MRIs now called 7 Teslas, which show increasing detail. And with functional MRI, where they're looking at how the brain actually works, they have seen definite connectivity changes. So the neurons are firing, connecting up properly, also in this midbrain and brainstem region. And James Baruniak, who's also a well-known ME researcher, has looked at this periventricular white matter area in the medulla oblongata, where the vagus nerve nucleus goes through and originates from. And we have to remember that our vagal nerve is the parasympathetic nerve. It supplies all of our organs, our heart, our lungs, our tummy, our abdominal organs, and that if that's overstimulated or not working properly, then that may account for a lot of a lot of the symptoms that occur. So he had some interesting information about that. Warren Tate gave a really excellent presentation that was really well received and understandable. I haven't covered it all here, but just to run over his susceptibility data. So what maybe makes people more likely to get ME and long COVID. So he studied 160 ME/CFS patients and 57 long COVID patients. And he found that you're more likely to develop those conditions if there was a familial tendency, so maybe a genetic link, so another family member who had a fatigue-like illness. If your prior health history as a child, if you were somebody who had more frequent illnesses and generally a slower recovery from childhood illnesses, and if you'd had a prior major stressful event in your life or an underlying condition. So genetic factors and then probably sort of environmental triggering factors that set off that susceptibility. Professor David Systrom works in Harvard and Boston, and he's a relatively new researcher in the ME and long COVID space. However, he's received $8 million worth of US worth of funding towards research. And he's got some really interesting findings in the neurovascular dysregulation during exercise, which it sort of helps to explain what's happening with the exertional intolerance. He does invasive cardiopulmonary exercise testing to do these studies. So this is kind of like the next level up. So not only is he putting people on a treadmill and testing the exercise with oxygen and all the pulmonary function and cardiac function with ECGs and things like that. He's also putting in an arterial line to check what exactly is happening with oxygen and that side of things, as well as a venous line to look what's happening with venous blood flow and pressures and with the heart. So it's pretty invasive testing. But he's found that there's no problem with people's heart function, no problem really with their lung function and how well they breathe and get oxygen, but that there's actually a peripheral limitation in their blood flow. So blood's not getting back to the heart as well as it should. It's called preload failure. And whilst there's lots of oxygen going through the lungs, that oxygen isn't being well extracted in peripheral muscles or systemically. So that's going to affect how well the cells actually can function. He also does skin biopsy testing, and this came up again across a number of presenters. And that skin biopsy testing shows that there's potentially a small fiber neuropathy that may be immune regulated. It may be regulated with COVID anyway through a kind of a blood vessel problem. But that neuropathy affects blood vessel tone, so maybe blood vessels can't constrict the smaller blood vessels to send blood back to the heart. It also affects pain. And so this is actually also a well-known finding with people with dysautonomia, POTS and that sort of thing. And his testing shows the same findings between people with ME and long COVID. So again, the similarity. So he's done a very small randomized controlled trial of pyridostigmine, which is mestinon used for myasthenia gravis. And some patients have shown a response. He's doing a much larger study, including with LDN, but we're too early to really know how helpful that is, or how useful. He also talked about using something called a shape test, which is a really well-tolerated 6-minute exercise test where you're standing up and down on steps, and much more easy to conduct, and that could have a much easier and better utility for exercise testing for post-exertional malaise and POTS and things like that for people with ME/CFS. And just his invasive testing results, he did notice that only came up positive if people were actually standing up or upright, not lying down exercise testing, which is an interesting finding. Once we got bamboozled by all the science, we moved on to some stuff that we could actually more easily understand and was quite well received. And Ros Vellings gave an excellent down-to-earth presentation. And I've stolen, this is actually one of her first slides that she put up, as to, how difficult it is for what the challenges are for clinicians and therefore for patients. And I would just like to say that when you go to an international conference, you realise just how esteemed Dr. Vellings is with the international community. They give her so many accolades for her contribution, making me emotional, contribution to ME over the years. So thank you. So what she talked about was that for the GP, when the patient comes in the room, it's opening a can of worms and it's really difficult. GPs go, oh my goodness, where do I start here? And it's a bit of a heart sink moment. That's not to say that it's a heart sink patient and a heart sink problem, but it's an overwhelming sensation. So went on, and this was also brought up by other clinicians who spoke at the conference. Dan Peterson, who's been around for a very long time, Dr. Judy Jurenko, and very, very few clinicians spoke, but these were brought up. So it's really hard to attract clinicians who want to have a special interest in ME. And that's because physicians and GPs primarily are really overwhelmed. They're overwhelmed at the moment by the amount of work that's out there in general, running a business, patient waiting lists, short staffing. They're overwhelmed by just this complexity of the illness. It's a very difficult and complex illness to get your head around and deal with. And they're sometimes overwhelmed by the complexity of the patient themselves. There's form filling, there's lots of, often lots of notes to sift through. There's multiple symptoms to try and sort out and make sure that you're not, that you've investigated those and thought about those carefully. And that's actually a very poorly remunerated area to get into. There's also a lack of clinician education at med school and beyond med school, so GP registrar programs and so on. For GPs that and other specialists that might be interested in ME, there's actually a real lack of peer support. So bouncing ideas off each other, knowing what other people are doing and keeping up to date. There's the usual time constraints and consultations. So as I mentioned, there's complex presentations, and this is not a quick and easy diagnosis to make. There's no diagnostic test to help us out, so it's based on pattern recognition and fulfilling a diagnostic criteria. And there's no specific treatment. So a management plan, and as I've said, this illness is quite a heterogeneous illness. It's very different for different people. And so management plan needs to be individualized, and it's also very time consuming to do that. There was a patient perspective as well. So Dr. Brianna Weigel is a young person studying at Griffith University, doing her PhD. And she did a longitudinal study of ME/CFS patients over 12 months. And basis of that study was she did show that, well, there was a significantly reduced quality of life, disability and functional impairment, and ongoing significant fatigue scores. And really what her study showed was what we all kind of know, but that the impacts of having ME are prolonged and they are profound. So there's a permanency about it, which kind of is what you need to do to show that ME/CFS could in fact be classified as a disability. So they have the same challenges in Australia as here. ME is not recognised as a disability there, and these findings could help towards that. And that at policy level, that should really include patients' lived experiences with ME. And of course that there's this significant economic impact for patients and for society as a whole of this illness. And once again, it came up time and again how difficult it is for patients to access clinical care. There was another study by a doctor in Victoria, and other speakers about how there is a mental health toll with having a chronic illness. And this person studied 62 patients with COVID infection and who were previously well. And actually the majority of those patients said they didn't have the same level of normal health as previously. And after 12 months, nearly half of the participants perceived their stress levels to be at a moderate or a high level. A significant number had anxiety and depression. However, she didn't I don't recall that she compared that to what well people were feeling, so difficult to compare. Where are we going in the future? So there was a few younger researchers, which was good to see, and lots of enthusiasm. There was some discussion about whether we should be careful not to just study ME in silos, and whether we should be having a more integrated approach and studying illnesses together that are quite similar. So ME, long COVID, Gulf War illness and fibromyalgia, which indeed is happening, and that sometimes the labels are less important. There was quite a bit of talk about how artificial intelligence may be very helpful in the future for studies with predictive analysis and developing algorithms and research collaboration, development of mobile health apps, wearable devices, which we already use, watches, monitors, that sort of thing, and invisibles. So that's things that just sit maybe on the table and somehow monitor what you're doing, your sleep, your breathing and activity. And then there was I guess there's a little bit of frustration that there's no new sort of medicines out there, and that really would be nice that the future for treatment is probably studying medicines that are already being used for other illnesses, and targeting those individual processes that we know about that are problematic in ME/CFS, and aiming really for phase 3 trials, which are the control trials that tell us whether something's actually any good for a particular illness. So just in summary, so overwhelmingly ME/CFS and long COVID are now kind of seen in tandem as studied together. ME is a really complex illness, and so therefore it's really going to be difficult to ever find one cause, one test that's good for everybody, and one treatment. There's this overlap with other similar illnesses, and that sometimes an integrated approach and sharing information can be helpful. Funding for research and treatment is an ongoing challenge. It will probably never be enough money, and this difficulty to access clinical care and a lack of clinicians that are involved in ME. Thank you for listening, and thank you also to ANZMES for helping to fund our trip to Australia to the conference.